Hello and welcome to Chapter 9. I am Miss White and today we'll talk about alterations in acid-base balance. In this chapter, we are going to differentiate between acids and bases. We're going to look at those expected pH measurements and thereof. We're going to compare contrast buffer systems involved in acid-base balance. We're going to look at the critical components that determine pH. We'll look at the clinical implications of acid-base balance, and we'll compare and contrast those mechanisms that lead to metabolic acidosis and metabolic alkalosis. And we will look at different concepts or clinical models related to fluid, electrolyte, and acid-base balance. So here, let's start off with our basic terms. An acid is a substance that donates protons in reactions, or they are substances that help donate hydrogen ions. We have bases that accept protons in reactions, or they accept hydrogen ions. pH is a clinical measurement of either acids or bases, and it is a ratio. We have our anion gap, which is the calculation of major cations and anions in plasma, providing an indication of acid-base balance. And normally when we calculate our anion gap, a normal value of an anion gap is somewhere between 10 and 14 millicues per liter. So that anion gap is a calculation of major cations and anions in the plasma, and the ions that we're discussing are sodium, chloride, and bicarbonate. Sodium is your cation, chloride and bicarbonate are the anions. So here in this example, we'll subtract the sodium level from that of or subtract the chloride and bicarbonate level from that of the sodium. So sodium's 142, you have chloride of 103, and bicarbonate levels of 27. What you'll do is add the chloride and the bicarbonate together. That should give you a value of 130. You subtract that 130 from 142, and that gives you an anion gap of 12, which would be normal. So that falls within that anion gap range of 10 to 14. We would consider that a normal value. So again, just note what that equation is. Again, anion gap is equal to the sodium level minus chloride plus bicarbonate. So you have to add that chloride and bicarbonate together and then subtract that value from the sodium. Here we're going to talk about buffer systems because acid-base balance is a result of our buffer systems, and the body is in this constant state of trying to maintain homeostasis. So the way that it resists pH changes is through buffer systems. So the main function of a buffer system is to have a mixture of acids and bases to help resist significant pH changes. So the body tries its best to keep the pH of the body between 7.35 and 7.45. And that'll be really important when we start talking about our arterial blood gases. But again, the body wants to stay somewhere between that. If it can maintain homeostasis, again, it'll stay somewhere between 7.35 and 7.45. So there are three types of buffer systems that the body uses to react to pH changes. And they are based on the time that it takes to help resist pH changes. So when we have plasma buffer systems, they react in seconds to help maintain homeostasis. When we look at the respiratory buffer system, that reacts in minutes to resist the changes in pH. And then when we have the renal system, it takes hours to days to react to the pH changes. So it happens in a progressive order. So you start from plasma, then you go to respiratory, and then you go to renal. So under plasma, you have three different types of plasma buffer systems. You have the bicarbonate buffer system, you have the protein buffer system, and you have the potassium hydrogen exchange system. All three of these fall up under the plasma buffer system. Again, all three of these react in seconds to help resist the pH change or help the body maintain homeostasis. When we talk about the respiratory buffer system, that's literally ventilation, and we will get into that in more detail in another chapter. But it helps to excrete or retain CO2 to help resist those pH changes. And then we have the renal system, which also reacts in hours to days to help absorb, excrete, or retain acids, bases, and ultimately your ions. You do have several areas of buffer systems under the renal category. And again, these take hours to days to react to the pH changes. But you have hydrogen ion elimination, you have bicarbonate conservation, you have the potassium hydrogen exchange. Yes, this features the plasma and under renal. So you do have potassium hydrogen exchange, and then you have the chloride bicarbonate exchange. So just note the differences and which ones fall up under which category. So here we are going to focus on the bicarbonate buffer system. And again, this is a type of plasma buffer system that reacts in seconds to help maintain homeostasis in the body. You'll notice that there are some strong acids and some strong bases noted on this equation. What I want you to know overall is that normally to maintain homeostasis, a strong acid can be substituted for a weak acid to have homeostasis, or there may be a strong base that, a strong base that is replaced by a weak base to help maintain homeostasis. So you have, again, strong acids and strong bases that are substituted by weak acids and weak bases to help maintain homeostasis. So when I discuss the concept of weak and strong, sometimes you do have too much acidity, and sometimes you have too much alkalinity or basic components within the body. So if you switch those out with the buffer system, it helps reduce either the amount of strong acid or the amount of strong base within that area. So again, the point of this slide is just to show that sometimes you have strong acids and strong bases that are switched out by weaker acids and weaker bases to help maintain homeostasis. So here we have the protein buffer system, and again, this falls up under the category of a plasma buffer system. And the protein buffer system is considered the largest buffering system in the body, and it does act fast, so it's large and it reacts within seconds. It does involve proteins such as albumin and plasma globulins within the vascular compartments of the body. It is multifunctional. So the reason why we have a buffer system with the proteins is that they are amphoteric, or that means that they can either be acids or bases. So again, the point of a buffer system is to help maintain homeostasis within the body. So if you have a molecule such as the proteins that can function as either acids or bases, if you have too much of one, then it can flip, or these proteins flip, and they go to an acidity or a basicity based off of what is too much in the body. Again, this is just to help maintain homeostasis within the body. And the other good thing about the protein buffer system is that there is free diffusion across plasma membranes, so the body does not have to work as hard to get these proteins across the membrane to help with acidity or basicity. So they do act as either acids or bases depending on the environment, and they do have the ability to either accept or donate hydrogen ions, which would make them either an acid or a base. So again, this is a large buffering system. It's a vast buffering system, but the main key point here is that they are multifunctional and they can serve as acids or bases and amphoteric substance to help maintain homeostasis in the body. So next we'll talk about the potassium hydrogen buffer system. So again, we are regulating pH. We're looking at how the body regulates itself from being too acidic or too basic or alkalotic. So again, this is in response to pH only. Now, when we talk about the hydrogen potassium buffer system, it is two cations going across the cellular membrane, and it is the change in these concentrations that helps either increase the pH or decrease the pH. So first we'll talk about how the pH is decreased, or how we have acidosis in the body, or acidotic state. If it's too much, And that is prompted by the increase of hydrogen ions. So we're removing those hydrogen ions from the extracellular area. They're moving inside of the cell, causing a decrease in the pH. So when hydrogen moves inside of the cell, it makes potassium go out of the cell. But remember, pH is based off of how much hydrogen ions you have in that extracellular compartment or in that extracellular area on the outside of the cells. So when we remove those hydrogen ions, we are essentially decreasing the pH because there's no hydrogen ions on the extracellular area. So again, that causes an acidotic state. But what that in turn causes is that as we're moving those hydrogen ions on the inside of the cell, we're increasing the amount of potassium ions on the outside of the cell simultaneously. So again, pH is dropping, but because the hydrogen ions are moving inside of the cell, potassium is increasing on the extracellular side. Now remember, a few slides ago, or even in the last chapter, we discussed that those levels that we talk about, the 3.5 to 5 millicues per liter, this is where that comes into play. So we're essentially increasing that potassium level, that 3.5 to 4.5, we're increasing that area of the cell with the potassium levels as a result of this buffer system. So again, when we have hydrogen ions move inside of the cell, that prompts the release of potassium ions on the outside of the cell. So on the outside of the cell, the pH has decreased. There are no hydrogen ions there anymore. And then it increases the amount of potassium on the extracellular environment. So we have two conditions that are formed there. We have an acidotic state, or we create an environment of acidity, acidosis, and we also have a hyperkalemic state because of those high levels of potassium on the outside of the cell. So in reverse, we have where the pH is increased. So when we move those hydrogen ions back to the outside of the cell, or to the extracellular membrane, we have more hydrogen ions, which causes an increase in pH. So again, when we have ions removed, or those hydrogen ions removed, the potassium is then sucked back into the cell. So that makes the potassium levels on the extracellular environment low. So now we have a hypokalemic state because potassium is low, and we have an increase in pH because the hydrogen ions are now, there are more hydrogen ions circulating in the extracellular environment. So this slide is going to talk about the respiratory buffer system. So now we have moved out of the category of the plasma buffer systems, and now we're talking about the big category, and it is a category by itself, the respiratory buffer system. So it reacts in seconds to the pH changes through the retention and or removal of CO2. So lungs are used to assist with the restoration of pH, but just know that the lungs are not a fix-all or end-all be-all. It just helps to restore, but it doesn't fully restore. So as a reminder, inspiration is where we're breathing in oxygen, and expiration is where we're breathing out CO2. So that removal or the expiration of that CO2 is where we may see acidosis or alkalosis in these individuals. Now, again, this will start leading into that conversation of arterial blood gases, but just know that CO2 is an acidic compound. So in high levels, that would cause pH to be low, okay? So when the pH is low, or there are low pH levels, chances are there's high CO2. That means that there's retention of CO2 in the body, and the lungs' response is to remove CO2 through increased respirations. So again, when we have acidosis, again, the CO2 levels are high. CO2 is an acidic compound, so high doses of CO2 makes the pH low. pH is low, making a acidotic environment. So the lungs' response is to remove that high dose of CO2 through increased respiration. So the body is trying to blow off that CO2 as much as possible. So the reverse in this buffer system is alkalosis. So that means the pH is high, and that means our CO2 level is low. So what the body will do to respond to that is to try its best to retain CO2. So you'll have a decrease in respirations as a result. And again, CO2 is an acidic compound, okay? It is acidic. So high levels of CO2 creates an acidic environment. That means pH is low. Low levels of CO2 creates an alkalic environment, which means the pH is high. The lungs respond to how high or low the carbon dioxide levels are. So again, if the level is too high for carbon dioxide, the body is going to remove that by increased respirations to remove that carbon dioxide. The body will also respond to low levels of carbon dioxide by trying to retain what it already has, so it will decrease the respirations as a result. Here we have the renal buffer system, and again, this is one of those bigger categories of the buffer systems featured in the body. Up until this point, we talked about the plasma buffer systems and the different subsets of that, and we've talked about the respiratory buffer system. So now we're at the kidney buffer system, or the renal buffer system, and there are four mechanisms that are up under the renal buffer system. We have hydrogen and bicarbonate conservation. We have potassium hydrogen ion exchange, and again, we see that with the plasma buffer system, but here we have that specific to the renal buffer system. We have the tubular buffer system, which features phosphate and ammonia, and then we have the chloride bicarbonate exchange. So all I want you to know here is that the kidneys are kind of the last overhaul when it comes to regulating acid-base balance in the body. Again, we have the plasma, which reacts very quickly within seconds. We have the respiratory effort that acts within minutes. And then the kidneys, they actually activate within hours to days, depending on how severe the condition is. So we won't necessarily go into specific details about these four particular buffer systems, but just know that once it gets to the kidneys, that's the longest time for the body to have that last effort to maintain homeostasis. So here we have two different types of alterations in acid-base balance. Specifically, we're talking about metabolic acidosis and metabolic alkalosis. And the key thing to remember about this section is that this is focused on the kidneys. So this is when that kidney buffer system is no longer working, and we have these different alterations based off of that. First, we'll talk about metabolic acidosis, and it is characterized by a decrease of bicarbonate ions that is caused by either a decreased production of non-volatile acids, a decreased secretion of acids by the kidneys, you have loss of bicarbonate ions themselves, or you have an increase in chloride ions. So all of these can trigger metabolic acidosis. Now, the thing about bicarbonate is that bicarbonate is a basic compound. So when you have loss of a base, that means the environment essentially becomes more acidic. Hence, we have an acidotic state or metabolic acidosis. And again, that is caused by adding more acids. That's the increased production of acids in general. You have the decreased secretion of acids by the kidneys, so the kidneys are not getting rid of the acids as they normally do. You have increased loss of bicarbonate. Again, a basic compound is no longer present, so it makes the environment more acidic. Or you have an increase in chloride ions, which is also a acidic component. So in order to tell if you have metabolic acidosis, you look at arterial blood gases. You can also look at a metabolic or electrolyte panel, and they have two different types, the basic metabolic panel and then the complete metabolic panel, and that's just a variance in different electrolytes that are featured on that particular panel. And then they'll look at serum ammonia levels and urine ammonia levels. And when I say serum, that is laboratory values that are taken from the blood. So you can have urine ammonia, which is taken directly from urine, and then you can have serum, which is taken from your blood work. As far as your treatment, you want to treat the primary cause of metabolic acidosis. You want to replace fluids and electrolytes and ultimately help to correct that pH. As far as your clinical manifestations, you have anorexia, nausea, vomiting, weakness, confusion, coma, vasodilation, lethargy, a decrease in heart rate, so you have bradycardia, flushed skin, and your lab findings are normally a pH of less than 3.5, which is, after or before that homeostatic level, 7.35 to 7.45. So to have an acidotic state, you have to be less than 7.35. And then you have bicarbonate levels of less than 22. Now, your book says 24 millicues per liter, but just know that really the value is 22 to 26. So anything less than 22 millicues per liter of bicarbonate levels would indicate an acidotic state in your patient. Next, we'll move into metabolic alkalosis, and this is an increase in your bicarbonate ions. And again, this can be caused by an overall decrease in hydrogen ions. It could be caused by an increase in the bicarbonate ions themselves, or it could be caused by a loss of chloride ions. As far as your diagnostics, it would be the same as metabolic acidosis. You'll look at arterial blood gases. You'll look at the electrolyte panel, your metabolic panels, and you'll look at your serum ammonia and urine ammonia levels. As far as treatment, again, you want to correct the primary cause. You want to replace your fluid and electrolytes and also help to correct that pH. Your clinical manifestations can tend to be asymptomatic, but if you do have signs and symptoms, they are more closely related to those of hypokalemia. So you'll see those cardiac arrhythmias, dizziness, hypotension, muscle weakness, leg cramps, anorexia, even abdominal distension, you'll see in metabolic alkalosis. As far as your laboratory findings, your pH has to be greater than 7.45, and your bicarbonate levels have to be greater than 31. Again, the normal value is 22 to 26, but greater than 31 indicates a more alkalotic state. So here's a really nice concept map just describing everything that we've talked about in the different areas of acid-base regulation and fluid regulation. So in this chart, you'll see the movement types. You have diffusion, osmosis, facilitated diffusion, active transport. And on the top here, you'll see the intracellular compartment versus the extracellular compartment fluids. And you'll see that with those changes, it'll either become more acidic or basic, and then that essentially affects the pH. So again, you may lead to a more acidotic state, or you may lead to a more alkalotic state depending on the movement of these ions. Again, for example, if your sodium is increased in the extracellular compartment here, that's a more acidic state that decreases your pH, and again it causes that acidotic state. But again, your buffer system is there, whether it's a type of plasma buffer system, respiratory buffer system, or renal buffer system. It helps to try and balance that pH back into where it's supposed to be, between 7.35 and 7.45. So I encourage you to look at this chart just to get an overall perception of what fluid and electrolyte and acid-base balance has to do with each other. So here are our clinical models as it relates to acid-base balance. We'll talk about heart-associated acidosis, renal tubulopathy, and also metabolic acidosis and parenteral nutrition. So the first one we'll talk about is highly active antiretroviral therapy, or heart-associated acidosis, and it is caused by nucleoside reverse transcriptase inhibitors, and normally you see these medications to treat HIV, or those that have been diagnosed with HIV. So the purpose of these reverse transcriptase inhibitors is to reverse the effects of the virus that would cause HIV. So the adverse effects are mitochondrial dysfunction, You have hyperlactemia or lactic acidemia. You have lactic acidosis, which all results in a pH of less than 3, which is a very severe state of acidosis. And it is also the result of impaired oxidative phosphorylation. So all this is saying is that these drugs, you have too much of this drug, and it causes all of these conditions, which ultimately results in the acidosis that you see in heart-associated acidosis. So again, hyperlactemia, that means you have high lactate levels, and that also indicates an infectious process, and it may also indicate a septic process depending on how severe it is. But a byproduct of that is acidemic states or lactic acidemia. So again, you have lactic acidosis as a result of too much of this drug and the adverse effects of this drug. So you have to have a diagnostic criteria. You have to have a history and physical, of course. And what is your history of the reverse transcriptase inhibitor use, or NRTIs? You have to have recognition of the clinical manifestations, which we'll discuss in the next slide. And as far as your laboratory findings, you have blood lactate levels that are elevated. You have off-balance electrolyte and blood pH levels. Again, those pH levels are low because it's an acidotic state. And they'll also look at your liver function test, because these work very heavily and severely on the liver. They are hepatotoxic if used in inappropriate amounts. So the treatment is determined by the symptoms. They may choose to alternate the selection of NRTIs. They may stop the NRTI treatment completely, and then of course you want to rebolus individuals with fluids that are having these types of adverse effects. So here are clinical manifestations, and they range from mild to severe depending on the use of your NRTIs, those reverse transcriptase drugs. And again, they are hepatotoxic. They work very heavily on the liver. So you'll see a lot of abdominal signs and symptoms come from that. So you will have that abdominal discomfort, you'll have nausea, vomiting, weight loss, and hepatic steatosis. Severe symptoms would include hepatomegaly, which is an enlarged liver. Your liver enzymes are elevated. That's your AST, your ALT, ALP enzymes. Those are all elevated. You may even see hepatic failure, coma, and then multiple organ failure as a result. So we'll talk about renal tubulopathy, and it is caused by genetic mutations in the renal membrane proteins, and ultimately it results in multiple electrolyte imbalances and also altered acid-base imbalances. So those imbalances are hypokalemia, hypochloremia, hyponatremia, and metabolic alkalosis. And you'll also see an increased level of prostaglandins in this disorder. There are different variants. You have classic Barter syndrome, Gleitman syndrome, hyperprostaglandin E syndrome, but all of these lead to renal tubulopathy. As far as your diagnostic criteria, you'll look at your urine and serum electrolyte studies. You'll look at the arterial blood gases because there are acid-base alterations there. You'll look at the anion gap. You'll look at with that anion gap if there's extra bases or if there's a base there. And you'll also look at urine-specific gravity. Normally, they'll do a renal ultrasound and also genetic testing to confirm whether this is an issue. Now, as far as treatment, focus on this. The kidneys are more closely associated with salt retention and reabsorption. So treatment of renal tubulopathy requires the correction of renal salt loss. So you have to replace salt inside of the kidneys. So you may see individuals receive fluid therapy that has more salt content in it to help replace that salt that was lost. Of course, you want to correct the fluid loss because everything has gone in these patients. And again, you'll see that with the clinical manifestations that we'll talk about in a little bit. But you want to replace that fluid loss, and you want to replace that electrolyte imbalance. So again, you'll have sodium and potassium supplementation. You may have drugs that are potassium sparing, which retains those potassium electrolytes. and you may have prostaglandin inhibitors to help with that inflammation response. So our clinical manifestations are a variety. We have general manifestations, which includes fever, vomiting, nausea, diarrhea, and again, the signs and symptoms of metabolic alkalosis. In pregnancy, you can see renal tubulopathy, and you'll see maternal hydramnios or increased fetal urine output in the womb. In early infancy and childhood, you'll also see increased urine output. So again, when your body is getting rid of all of these fluids, water tends to follow sodium. And again, when you're losing sodium, potassium tends to go with it. So you'll see all of these alterations. That's why it results in the hypocalcemia, hy- hypokalemia, hyponatremia, hypochloremia, and you may even see hypercalciuria, which means high values of calcium in the urine. So here we have metabolic acidosis and parenteral nutrition. So this is TPN. And again, this is a nutrition supplement that is delivered through a central line in individuals that are normally malnourished. So the pathophysiology is that you're getting nutrition, and this is the delivery of water, amino acids, lipids, glucose, vitamins, minerals, everything that is sustainable to the individual to get proper nutrition. This is where it streams from. And you can even get it from having additives like hydrochloric and organic acids or bases that are added to your parenteral nutrition supplement. So your diagnostics include ABGs. It's an acidotic state, so normally your pH levels are low, less than 7.35. And then you also have low bicarbonate ions. And again, bicarbonate is a basic compound. It's considered basic. So if you have low levels of a basic compound, then you'll see this acidotic state here. In some cases, you'll see low CO2 levels or carbon dioxide levels, and this is due to respiratory compensation. Again, we'll talk a lot about this when we start doing ABGs, but just in a simple sense, CO2 is normally an acidic compound, but it'll also drop to help compensate through respiratory effort. And again, we'll talk a lot about that when we do ABGs. You have electrolyte imbalances, and you have large anion gaps that indicate metabolic acidosis with TPN administration. So the treatment is to adjust the TPN solution and the components and the intake. Maybe they just have to adjust the electrolytes or the amount, because when you have TPN, it's not all the same. Different individuals have different nutrition requirements. So if an adjustment has to be made, it'll be based off of that person's nutritional status and what they need to be functional. You may correct the bicarbonate to help with the base deficits. You may replace with bicarbonate. You may have to hydrate these individuals, and you may have to also provide oxygen because the CO2 and the respiratory effort, you're breathing more to help compensate for, to get that, or you're breathing less to help compensate for oxygen and CO2 exchange. So again, when you have TPN, this is a condition that you have to look out for, because if it's left unchecked, it could result in death. Your signs and symptoms include your normal anorexia, nausea, vomiting, weakness, lethargy, confusion, coma, vasodilation, decreased heart rate, and flushed skin. And in extreme cases, you'll see those cardiac dysrhythmias, seizures, and coma. So that concludes chapter 9. Make sure you review your chapters in the text. Make sure you complete your guided learning questions and system disorder cards. Look at your case studies and activities. Make sure you review everything, your clinical manifestations, diagnostics, treatments, and application to your clinical models. Quiz yourself and quiz others on this information, and make sure you're able to answer those questions in the textbook. If you have any questions, feel free to reach out to me, and I'll be more than happy to answer your questions. Thank you and have a great day.